Hello. Good evening, fellow friends and loved ones. Yes, it's once again a very great privilege and a due honor to come to your homes. And as we continue our discussion on various health conditions, yes, last week was exceptional. We had a wonderful discussion, and this week also we are continuing our discussion, and it promises to be very interesting. Yes, I'm sure it's one of the common conditions that we may have, but it's on a low key. So I'll kindly crave your indulgence to join us in the discussion. You can share the page to your various contacts. Yes, you can share the page, the link, and then others also can benefit and enjoy the discussion. Okay, so we begin this discussion in the name of the Father and the Son and the Holy Spirit. Okay, so um this evening discussion is on a topic back pain, but specifically there's a condition we called spondylolisthesis. Yes, and that is where we have a part of the body involving the bones shifting either forward or backwards. So we'll be having a very extensive discussion on this condition. So people say I have back pain, my back is paining me, but there could be so many issues that could result in back pain. So when you come to a specialist, that the orthopedic surgeon, the physiotherapist, any of them, they could assess you and see exactly what is at your back, and then they give you the treatment as needed and as very possible as you need. Okay, so outline is the definition of the condition, the clinical anatomy, the epidemiology, the characteristic of the condition called spondylolisthesis, or the bone shifting forward or backwards, and then differential diagnosis, and then with the local examinations, outcome measures, how we manage this condition, the medical aspect, the conservative, either the surgical or non-surgical, the physical therapy, the lifestyle modification, how we are able to manage this condition and to prevent the condition from becoming quite worsened. Okay, so yeah, this topic is actually very interesting, and then as we know, there will be some pictures after that to be able to see how this condition looks like, and then some exercises that you can do to treat this condition. Okay, so actually this condition involves the change in position of some parts of the bones at our back. So at our back we have so many structures at our back. We have muscles, we have tendons, we have ligaments, we have bursae, we have bones, we have blood vessels, we have nerves, so many structures there. But a very important structure that we'll be talking about today is the bones. The bones. We have bones at your back we call vertebrae. Yeah, vertebrae. A scientific name for bones at your back are vertebrae. And the spinal cord goes through these bones. And then it's very important because when the spinal cord doesn't go to the bones, the spinal cord will be exposed. And immediately the spinal cord is attacked or is injured, you could have paralysis. You could have maybe your hand not moving again, your leg not moving again, or you could even lose so many functions of your body, and then ultimately you could die, because that's the main place where the brain communicates with to the body. Okay, so we're talking about the bones. So scientifically it's called the vertebrae. The vertebrae. Okay, so when any of the bones at your back shifts either forward or backwards as a result of so many factors that we'll be talking about very soon, yes, it could result in this condition we call the spondylolisthesis, or to be specifically stating, shifting of the bone forward or backwards. Okay, so we say scientifically that the slippage of the vertebral body, that's the slippage. That is, slippage means shifting. So when something slips, it means it's shifting from the normal point of position. So slippage of the vertebral body with respect to the adjacent vertebral body. So at your back, the bones lie on each other. So one bone, if this one bone, this another bone, so they sit on each other, but they don't sit directly on each other. We have something we call cartilage that prevents them from sitting directly on each other. So this helps to prevent wear and tear, because when the bones sit on each other, they can cause scratches, and this could cause wearing of the bone, and then it could result in pain, extreme pain. So some people complain of pain, and this could be as a result of this cartilage going down. But I'm talking about that one today. I'm sure in subsequent ones will be discussions, will be talking about this condition. And so we're talking about where the bone shifts forward. So if one bone is sitting on each other like this and the cartilage is in the middle, there's a tendency, or there's likelihood of one bone shifting forward and the other also like this. So if this is the bone, I'm sure you can see from this angle. So if there's a bone sitting on each other, one could shift forward like this and then cause instability at your back. There are so many grades of the severity of this condition, which we'll be talking about very soon. So there's a point where there could be a little shift forward like this. There could be also minimum shift, there could be maximum shift, and there could be total shift. Talking about this very soon. So this condition we are talking about is spondylolisthesis. And so this condition can be congenital, that is at birth. It could be also acquired through so many reasons which we're talking about, and then it could be idiopathic, where it could be unknown cause. It could just happen that the bone shifts. Okay, so there's a classification. It's a man called Maydens classification. He classified this condition per the degree of slippage of the disc. So as and when the bone shifts, so if it shifts a little, then he says this is the grade at which the condition is. So he classified this under about 5 grades of classification: 1, 2, 3, 4, 5. Here the degree of the shift of the bone forward. Okay, we'll be showing some pictures very soon, so just stay tuned. Just keep relax. Okay, so actually this condition mostly occurs at your lower back. Yes, so that is where the whole body weight sits on. So when you sit down, your head and your shoulders and your stomach all sit on it, on your lower back. And also when you are walking, to your waist and your lower back are supposed to control your movement. That is turning, bending, straightening up. So many movements are controlled by lower back, and lower back has very, very strong muscles. And then these muscles include quadratus lumborum, erector spinae, and so many muscles and ligaments. And these are very, very important structures that help to keep your back very, very strong, and then prevent you from injuring any of the structures at your back. Okay, so we should know one thing that we have to take notice is that regardless of the degree of the spondylolisthesis, there's a condition that we call spondylosis, where I said we're talking about maybe some other time or some time to come, where we have the bones rubbing on each other, where the cartilage in between the bones come, or they are worn out. So when the bones scratching each other, the body is likelihood, or has a likelihood of compensating by either the bone shifting forward, or it could be that the integrity of the bones are compromised and they scratch against each other. So this will cause the bone to shift forward, or sometimes backwards. But backwards actually is on a small percentage of people who have their bones shifting backwards. But most of the conditions that we treat at the hospital, they have the bone shifted forward. That's the kind of spondylolisthesis at the hospital. There could also be fracture of a structure in the bone called pars interarticularis. So we'll show you the picture very soon, and we'll be able to appreciate it. And then when there's a fracture in the pars interarticularis, we call it the isthmus spondylolisthesis. So you have so many types of spondylolisthesis, which we'll be talking about very soon. So these bones also help to maintain the normal framework of the body. Without our bones, we'll be disorganized. We all have disorganized bones. These are bones shaped or moved to a particular direction, will look different from the normal human being. Okay, so we have, as we talked about, the bone shifting forward or backwards. When they shift forward, that is one bone that is on each other. If it's like this and the bone shifts forward like this, we call it anterolithesis. Anterolithesis. The general name is called spondylolisthesis, or the bone shifting backwards or forward. That is the common name. But when the bone shifts forward, the scientific name is called anterolithesis, and when the bone shifts backwards, it's called retrolisthesis. Yes, so in the case where you have this condition, the doctor can, or the physiotherapist can diagnose the condition as this, and I'm sure you both understand the reason why he or she diagnosed the condition as such. Okay, so there has been so many researches that have been carried out outside, and then there's a man called Dare Ly, and his other colleagues, they analyzed that, and they found out that there is a relation between this generation, that is when the bones lose their strength. The bones contain a substance we call calcium. So when the calcium content in the bone becomes less, then we call it this generation. And then this man found out that there's a relation between the age and the duration or the severity of the symptom that the patient presents to hospital. So if the patient or the person is getting older, there's a likelihood that the bones lose their calcium content at a faster rate, and this could cause the condition we're discussing today as spondylolisthesis. Okay, so that's one of his reasons for this condition occurring in elderly people. So we're talking about now epidemiology. So this actually is the disease itself, that is the types of the condition. So we have about basically three main types of this condition. We have the degenerative type of the spondylolisthesis, we have the isthmic spondylolisthesis, and we have the dysplastic spondylolisthesis. So these are the three main types of spondylolisthesis that we have. That's the bone shifting forward or backwards. The degenerative type of the spondylolisthesis actually occurs in the elderly people, that is adults, and then scientifically it's been shown by research that it occurs more in females than in males, and then also more related to people who are obese. Yes, this means because of the fact that in females occurring more is because of the fact that they have tendency of having their hormones or the hormone level reducing with increasing age. Okay, so that is one main factor of the increase in the prevalence in females with respect to increasing age. And then the second type is the isthmic spondylolisthesis. Yes, actually this condition or this type of spondylolisthesis is common in adolescents and a younger population, but scientists or researchers have shown that it could go unrecognized as the person grows, but then it shows up when the person gets to the elderly stage of age. The person may not have this generation, but then could have a spondylolisthesis. But then we can trace it to the isthmic type of spondylolisthesis. We mentioned the fact that the isthmic is as a result of the fracture of the pars interarticularis, which will be showing the picture very soon. It's very, very nice picture. Okay, and then the third type is the dysplastic spondylolisthesis. Yes, the third type, which is actually in children, as a pediatric population. There could be so many conditions that could result in the dysplastic population. It could be the malformation of the bones at the back, and these could result in the shifting of the bone either forward or backwards. But more importantly, or more prevalently, it's shifting of the bones forward, resulting in recalled spondylolisthesis or anterolithesis. Okay, so it's shown that this type of spondylolisthesis, that is dysplastic spondylolisthesis, actually it's on a rise, but then not so much as the isthmic type of the spondylolisthesis. Of the prevalence, 6 to 7% in people who are less than 18 years, but then on about 18% for people who are in the adult population when an MRI was taken among a section of population outside. Okay, so this type of spondylosis it's actually something that we need to carry out actually in the in the country, yes, in Ghana. We are hoping to have more researches carried out in this aspect of our continent, Africa. Okay, so we have so many types, as we mentioned, so many grades of the spondylolisthesis. That is the bone shifting forward or backwards. We have, I mentioned earlier on, we have the grade 1 to grade 5. But then researchers have shown that yes, grade 1 type of spondylolisthesis is actually the more prevalent type. Grade 1, that is when the bone shifts a little bit forward, but does not really cause any harm or any so much discomfort. But then when it's recognized early, a very good treatment could bring the bone back to its normal position, and then the person lives a normal lifestyle. Okay, but then at the bones at the back are grouped under levels. So your neck has bones we call the cervical vertebrae. Your upper back has the bones we call the thoracic vertebrae. The mid back also has the bones called the thoracic vertebrae, including the lumbar vertebrae, and the lower back also has a lumbar vertebrae. Just under the lower back we have the waist, and then we have the genital organs around the side. And so we have the lumbar vertebrae. Just under the lower back we have under the lower back we have the sacral vertebrae, and these actually help to give our body a very, very upright posture. Any shift in these bones could cause a disorientation in our body structure. So specifically at the lower lumbar, that's the lower back, we have these bones called the lumbar vertebrae, and these help also to give a very good and upright posture to our body. And so there's a part of the lower back, the bones in the lower back, called the L4, L5, and S1. These are all scientific terms. I'm sure the pictures will give you a very good understanding of what we're talking about very soon. So we have the L5, L4, L5, and S1 at the lower back. So in the case where the L4, so I mentioned earlier on that they sit on each other. So you have the L4 and the L5, and you have the S1 at the lower back. So these all help to give good structural position of the lower back, and also the spinal cord ends around that region. And then there are small nerves that goes out into our legs, into our feet, and this helps to give us sensation. So when this bone, this L4 and L5, when the L4 that is sitting on the L5 shifts forward like this, that's what we call the spondylolisthesis. Very simple. I'm sure you understand it. When the bone that sits on each other, we call that one the proximal type. When we say proximal in scientific term, it means the one that sits before, or that one comes before. And when we say distal, it means that the one that comes after, or just after. Yes. So the proximal one here like this, and the distal one here. So this, if this L4 at the lower back, that's a lumbar vertebrae, and this L5. So when the L4 shifts forward like this, it's called spondylolisthesis or anterolisthesis. And then there's the likelihood that the L5 and the S1 also, there could be shifts. So the L5 can shift off the S1, and this also could result in the anterolisthesis or spondylolisthesis. So scientists have carried out researches in it, and they've shown that the L4 on L5 have a higher prevalence of occurrence of this condition. So it simply means that more of the conditions pertaining spondylolisthesis are a result of the L5 on L4 and on L5 type. So the L4 sitting on L5 have more prevalence, that we have more people or patients reporting the hospital with the L4 on L5 spondylolisthesis other than the L5 on S1. Okay, so actually this condition also doesn't have any respect of persons. Yes, it could be in an elderly person, it could be on a younger person, it could be on an adult population. Yes, so there was a man called Rorty. He also had classifications of this condition, and then we'll be talking about his condition, his classification very soon also. We had so many types. We have the type 1 to type 5. Yes, but then there could be so many causes of this condition. We have degenerative type, we have the ischemic type, we have the traumatic type, and we have the dysplastic type. we've talked about the degenerative type earlier on, where we have the bones losing their calcium content. So every bone in our body has a substance we call calcium. So when this calcium depreciates or loses its quantity or amount, there could be weakness in the bones that could cause instability in the bones, and they could shift either forward or backwards. But specifically, per this condition we're talking about, shifting forward, it could result in anterolisthesis or spondylolisthesis in general. So it could be also as a result of trauma. That is when you have someone blowing your back, or probably you've had an accident. Yes, the bone can shift forward, and then you could have spondylolisthesis. Okay, and then we mentioned the fact that this plastic, where it occurs in children, where there could be conditions. We have some conditions such as spina bifida. Yes, spina bifida, where we have the we have the central nervous system. As it's growing in the child, it comes out, and if it comes out, it mostly it's formed in the body. So the brain forms the central nervous system, and then we have the peripheral nervous system, that's the spinal cord. So down there at the lower back, there could be protrusion out of the lower back or the mid back, and these could have other side effects, and then it could result in spondylolisthesis in the children population or the pediatric population. Okay, and there could be also a result of also pathologic reasons, or we will say pathologic spondylolisthesis, and this could be as a result of infection. So we have infection in the bones. So I'm sure we can refresh our minds from last week's presentation. We talked about osteomyelitis. If you have infection in your bone, you could also have spondylolisthesis, because then the bones will be unstable, and there could be shifts in the bones, and it could result in anterolisthesis or spondylolisthesis. It could also be as a result of neoplasm. That is, we have cancer of the bone. There could be weakness in the bone and then shifts in the bone. This could result in spondylolisthesis. Some of the risk factors that can cause this condition are scoliosis. That was one of the first topics that we talked about. So if you want to hear more of scoliosis, you can just check on Facebook. You can just search on my page, and I'm sure you get the discussion. Or you can private mail me, DM me, and on Facebook, and then I'll send you a link of the discussion on scoliosis. So scoliosis is actually as a result of shifting of the back bones to one side, and these could cause also the bone to shift forward, and then cause spondylolisthesis. We've mentioned spina bifida. Yes, so these are all risk factors, and this could lead to spondylolisthesis. So we mentioned a man called Ross. Yes, he classified this condition as in grades. So per the degree of shifts or the cause of this condition, then we could grade it into under 5. So we had type 1, type 2A, type 2B, type 2C, type 3, type 4, type 5. So these were all main reasons we could have, where we have fracture of the bones around the side, and then also degenerative reasons, where we could classify the type 3 to be as a result of degenerative conditions such as this degeneration, and also the type 4 being as a result of trauma, that is the bone being fractured or a high impact onto the bone, and then the fifth one, which is as a result of neoplastic reasons such as cancer. Okay, so yes, there are so many clinical presentations of this condition. That's the characteristics. So what are the symptoms that we can notice from this condition? So when someone comes to the hospital, or see someone around and he complains of some of these symptoms, you can see the person is likely to have spondylolisthesis, but not definite unless being finally diagnosed by the doctor or the therapist. So the person could have intermittent and localized low back pain. So the pain actually is at the lower back. It doesn't move down into the legs. The person doesn't have pain radiating down into the legs. The pain is mainly at the lower back. Yes, it's centralized there. The person, we mentioned that it could also occur in the neck, and so the person has a central or localized pain in the neck. The pain doesn't go into the shoulders, the person doesn't have numbness, and it's just pain around the side. And there could also be increase in pain when the person extends. When you say extend, the person shifts backwards. So if the person does this, the person complains of pain at the lower back because the bones are shifting forward. And so when you are stretching like this backwards, there could be extra or excessive pushing of the bones forward. And remember that we mentioned earlier on that the spinal cord goes through the bones, and so when you are pushing more forward, that means you are causing displacement of the spinal cord, and this could cause severe injury. There could be paralysis. Yes, if you don't, there could be total weakness or total loss of movement in your legs if you don't stick very cautious or you don't report early. You could injure your spinal cord as a result of this condition called a spondylolisthesis. So let's take into consideration when we notice these symptoms as at pain at your lower back, you need to report to a doctor, or any pain in lower back you need to report so that we can rule out this condition called spondylolisthesis and then treat any other condition as such. There could also be pain when we touch the side. So when we touch lower back, especially the point of the spondylolisthesis, when we touch the side, there could be increased or exacerbated movement, that is exacerbated pain with the touch. Okay, so it's showing that the most comfortable position with less pain is lying on the back. So when the person lies on the back, that is very good and appreciable pain level. So the person doesn't complain of pain too much when he lies on the back, but when he lies on the stomach, the person is very uncomfortable on the side to relatively uncomfortable. Okay, so the person also has low back pain. Yes, as you mean low back pain. And then there could also be atrophy of the muscles. When we say atrophy, it means the muscles can lose their size. Muscles can reduce in their size at that specific side, and maybe you might not see it well, but then the orthopedic surgeon or the physiotherapist is more likely to see it better or clearly. Okay, so there could also be tension in the hamstrings. I'm sure we've heard hamstring before. Hamstrings are actually the thigh, the back of your thigh. There's a structure or their muscles at the back of the thigh we call hamstrings. And then I'm sure we've all had muscle pull before. So muscle pull. So at the back of the thigh, footballers who play football, actually they are likely to have hamstrings when they don't train or they don't do warm up exercises. And so when you have tight hamstrings, and you could also have spondylolisthesis, it could be a signal that you have spondylolisthesis. And also there could be spasms, as we mentioned, muscle pull, and then this could result in spondylolisthesis, or it could be a sign of spondylolisthesis. And then, but less often, the person will have bowel or bladder dysfunction or incontinence, but it means the person cannot control the going to the washroom as best as possible. But this is actually rare. This symptom actually is in the high grade, the most worst form of the spondylolisthesis. It doesn't really show at the earlier stage. Okay, so actually it can occur with other disorders, and then it's seen to have a link with some conditions such as the spina bifida. We mentioned that spina bifida occulta earlier on, and could be as a result of scoliosis. We mentioned it earlier on, and then spinal stenosis. When it is spinal stenosis, it means the reduction in the level of separation of the bones. So when the bones are compressed, the more it could also result in the bone shifting because of the discomfort in the bones. They want to find a way of separating each other. Then either they move forward or backwards because compressing themselves becomes a discomfort. So you need to separate each other. Okay, so I'm just giving my view of the reason. You say that like poles repel, so the bones are like poles, so they repel against each other. So they try to move against each other when they come into contact with each other in the absence of this cartilage. Okay, so we talk about some differential diagnosis. meaning other condition that could look like this condition called spondylolisthesis. So we have spondylosis, we have metastatic disease, that is a cancerous disease, we have low back pain, we have osteoarthritis, we have neuroforaminal stenosis, we have spinal stenosis. Okay, so these actually could look like, yes, spondylolisthesis. Okay, so how we diagnose this condition? So we do it through physical examination. So the orthopedic surgeon or the physiotherapist will examine you, will go to a procedure we call a step-up sign, and then when he or she palpates the back of the back, you could complain of pain at the lower back, and you could also see a change in the level of alignment at the lower back, and this could mean that you could have a spondylolisthesis. You could also do a straight leg raise test, and so that means that is actually a physiotherapy diagnosis of this condition. So it involves the patient lying on the back and then raising of the leg upwards. So if the patient complains of the pain in raising of the leg upwards, it could be a sign of the person having spondylolisthesis. But then radiological examinations also help to confirm our impression or what you are thinking about. So we have x-rays, which are very definite diagnosis of this condition because they involve bones. So the x-ray could help us to identify whether the bone is shifting forward, and specifically the grade, that is the level of shift, either forward, small, medium, moderate, or severe. And then we also have the CT scan, and this also helps us to be able to diagnose this condition very, very effectively. We could have an MRI, which actually does not really give a very conclusive diagnosis of the condition because the bones are not so clear, but they could help. The X-ray is actually the most definite one that helps us to diagnose this condition. We have something we call outcome measures. So these are questions that help us to see the level of improvement of the condition as when the patient is undergoing treatment by the physiotherapist. We have something we call the short form testis questionnaire. We have that helps us to see the level of the disability of the condition, and as time goes on, we see the level of improvement. We have the numerical rating scale to see the level of pain of the patient. Then as time goes on, we can see whether the pain is coming down or is becoming worse. Then if there's a need to refer to another specialist, at maybe the orthopedic surgeon, we do it as best and as early as possible. Okay, so aside the radiological examination, also we have the medical management. So we could have the patient being given medications to relieve the pain per the grade. We could also have heat. So in the first week or first 3 weeks, they could do a cold therapy. You could do ice, but after 3 weeks, we could switch to heat, that is using hot water bottle at the back, or machines we can use infrared, we can use the hot pack at the back, and this helps to relieve the pain, followed by minimal or moderate exercises, and these have shown to improve the level of function of the patient. We could also do traction, that is we could have separation of the bones depending on the level of the shift. This is very, very important by the specialist, because when we're able to tell the level of the shift, then we can give the very good treatment to the patient. We also have conservative treatment for this condition. It involves resting. So for the first instance, we advise the patient to reduce activities as best as possible. If the person is a workaholic, the person has to either refrain or work at home or reduce his work totally, and then also involves also avoiding movements such as lifting, bending, and then engaging in sports. If the person is a sports person, the person can take leave of the sports for some time and then treat this condition as such. The person is given pain medication, analgesics, and then we have something we call NSAIDs, non-steroidal anti-inflammatory drugs, and this helps to reduce swelling at the specific part, lower back, and also improve the level of function of the patient. Also, there could be injections given to patients if the pain is so severe. We call the epidural steroid injections, and this helps to reduce the level of pain. And then if the pain is also radiating to other parts of the body, also it helps to minimize them. And then a very important, in fact a key treatment is using a brace, or we call a lumbar corset. This helps to stabilize your lower back and then prevent extra movement, and also helps to allow the exercises that are being administered to be of effective use or effective administration. Because when you do exercise and the bone is shifting back to normal alignment, if you don't stabilize the lower back, any movement that you do could cause and return back to the pain that even brought, or it could worsen the case. So a lumbar corset is actually a device that we strap around our waist to help to support our lower back. Okay, so when these conservative methods are tried and then we don't really see any improvements, we also go through the surgical means. But then it's shown that about 10 to 15% of the population, general population, have this tendency of going through the surgical means. The early population, actually, we don't really have a good advice on going to surgical means. But then if the need be, the orthopedic surgeon has his own discretion to be able to carry out a surgery on the patient. Actually, there's no definitive standard for surgical treatment. It depends on what the surgeon comes or concludes on. And surgical means could be operative intervention. That is when you go to surgery, and then this could be decompression of the lower back bones, where we can increase the separation of the bones. And there could also be fusion. So if the bones are shifting too much forward, you could fuse the bones to avoid the likelihood of causing too much pain. And then any other advice for the doctor or from the physiotherapist will give the patient to prevent any other further injury. Okay, we could also have, so we have the two main surgical interventions of the decompression and then the fusion, with or without instrumentation. Okay, and so other exercises that we can give as physical therapists also are minimal exercises. We have the isometric exercise, so we advise the patient to squeeze the tummy. This helps to improve. Okay, yes, so it also helps to improve the level of strength at the lower back muscles. Yes, and so we should just take a very close cue in terms of physical therapy for this condition called the spondylolisthesis. So physical therapists also play a very important role to push the bones back, because the bone is moving forward. So we have exercises such as core stability exercises that help to strengthen the back muscles. Okay, and we have so many exercises. So if the bone is going forward, we could allow the patient to lie on the back and then bend both knees and push it backwards. We call tranquil exercises. This helps to push the bone backwards and strengthen the muscles. We also have balance training exercises per the degree of the shift of the bone. We also have hydrotherapy. We have endurance training of the muscles for people who complain of pain. So depending on the level of severity of the condition, then we can give the very, very appropriate exercises. Okay, so there's a man also called Pati Pavanech. Yes, he and his colleagues also stated that when you use a corset, you are likely to improve your walking distance. So people who have this condition actually have pain, so they're not able to walk very long distance. So when they use a corset, that is the waistband, they're able to walk longer distances, and also there's less pain. Okay, and they say that it's a very good tool to be able to manage this condition. Okay, So aside that, you can also do a massage, that is a gentle massage in case there is pain, and also as we mentioned earlier on, we could use the heat, yes, heat to relieve the pain. Okay, so finally we'll talk about, so there have been so many research that have been carried out, and then it's shown that this condition called spondylolisthesis is actually treatable when recognized early. When it's not recognized early, it could be worsened and could have so many um, um, disastrous effects. So then, if you have a complaint of back pain, you need to report to your physiotherapist or your doctor as early as possible so that the appropriate treatment can be given out. So some key things that we have to consider is we have to make sure that we report as early as possible if we have back pain, and then as we are treating too, we also involve the dietitian in case you are overweight, because scientists have also realized that increased weight also is likely to predispose you to this condition called spondylolisthesis. Okay, so this condition's treatment involves a multidisciplinary approach. So involve the orthopedic surgeon, involve the physiotherapist, involve the dietitian, involve the psychologist, and then we all come together to give the very good treatment and a good outcome for this condition. So I'm sure we've learned a lot from this condition, but before we leave, we just want to look at some pictures pertaining this condition, and then we go on. Okay, so yes, so this is what I was talking about earlier on, the pars interarticularis. Okay, so this is the pars antiarticularis. So this is what I was talking about. I'm sure you can see it now. Yes, pars antiarticularis. So if there's fracture around this area, there could be spondylolisthesis. So you can see it here now. This is very visible. The pars interarticularis. It's a part of the bone. Pars interarticularis. Okay. So these are some of the exercises that as physiotherapists we teach the patient. So you can see here the movement. So the person bends the both knees and holds and relaxes. You have the double knee to chest exercise. So you have the, you cross the leg. You can see the patient here. You can see he has crossed the leg. You can see. Yeah, I'm sure you can see it. These are some of the exercises. Dead back exercises. You have the pelvic tilt exercises. Yes, and so these are all exercises that help to treat this condition called spondylolisthesis. So these are some of the exercises also. You can see, yeah, one, the pelvic tilt. You can see the gluteal stretch exercises. You can see the dead back exercises. You can see the quadrip arm leg raise exercises. You can see the side plank exercises and the double knee to chest exercises. These are all exercises that as physiotherapists we go through the patient to treat this condition. These are some of the exercises to, so you can see some of the exercises there. Yeah, very explanatory. Okay, so this is what we call the spondylolisthesis. You can see the first bone here is a very good alignment, but the second one here is shifting forward. If you compare here, you see this one, this is very whitish here, this is a bit reddish. This is shift a little, but then compared to the third one, you can see it has shifted forward. You can see it here, it has shifted forward. If you look at it closely, this side is okay, this side is shifting forward. You can see from the alignment here shifting forward, but this one has shifted. You can see there's a shift here. You can see the red mark here. This red mark here shows the level of the shift. You can see it here. This one is fine. This one is fine here. There's no red mark here. This is a little bit of shift here, and then this is worse form with an increasing pain. Actually, this type is the initial stage where we have the spondylosis, but then if it's not treated early, there could be spondylolisthesis. So you can see the spondylosis is actually a precursor, that is lead spondylolisthesis. So this is the spondylolisthesis picture. Yeah, you can see it here. The bone has shifted forward here. That is the L4 and F5 spondylolisthesis. Yeah, so this is the X-ray of the bone. You can see the X-ray here. You can see this is the normal alignment of the bone. This one, but this one has shifted from normal alignment, has shifted forward, and this will cause spondylolisthesis. So this is also an example. You can see here, this is a worse form. It can be shifted so much. This is a normal one, the normal one here, and this is the worst form, the worst form. Okay, so these are all grades. We have the grade 1, sorry, we have the grade 1, grade 2, grade 3, grade 4 type. This is small, medium, moderate, and severe. Okay, so these are the calculated degree of shift. So we have 25 degrees, 25%, 50%, 70%, and 100%. These are all pictures. You can see this is a more extensive explanation. This is an X-ray of the shift. You can see it here, very visible here, the shifts of the bone here, L5 on S1. These are all examples, the shifts here. Okay, another one here, another one. Very good explanation. This is very good presentation, the shifts here. Another one. Yeah, these are all pictures. These are all pictures. And this is a very one of the type of spondylolisthesis. That's the degenerative type. Okay, so this is another one. So this gives a summary of what we talked about today. Okay, so this is an X-ray. So this is a surgical intervention. You can see the bone has been interlocked by screws, and this helps to stabilize the bone to prevent further complications. Okay, so these are all pictures. These are all pictures. These are all pictures. Okay, these are all pictures. Oh. All right. Wow, what a wonderful time today. It's been awesome. I'm sure we've learned a lot with the pictures and everything. It serves a good memory of this condition. So without much ado, we bring an end to the discussion today. So if you have any questions, you can private mail me. You can put it on our Facebook wall, and then we will answer you accordingly. Any questions, any comments, any contributions, it's warmly accepted. So thank you very much. There's some people joining in and out. I can see Ajua here and others here. Okay, so if you join in later on this presentation, you can the video will be uploaded soon on a Facebook wall. You can watch, you can share the video among your colleagues, your friends, and loved ones, and we can learn a lot, and we can prevent the condition from occurring, and we can also treat this condition. So thank you very much for your time. May the good Lord be with us. Have a blessed week, but not forget our next presentation is on a very also interesting topic called waist pain. So if you have waist pain, and then scientifically it's called sacroiliac joint dysfunction. Waist pain. So if someone says in the Tree dialect, in the Ghanaian Tree dialect, we say my waist is paining me. So what are the causes? What are the treatments for this condition called sacroiliac joint dysfunction? So let's join us next week, and then let's share the links and the pages also and the videos. And may the good Lord with us all. Have a blessed week. May the Lord protect us. May the Lord cover us. And take care. You're blessed. Bye.